Thanks very much for inviting me to present some research on tapering at the occasion of World Tapering Day. And thanks very much, Carol, for organizing all this. It's really fantastic. So what you see here is the Netherlands. We call it the polder. The polder means it's all flat and there's plenty of water. And we're always trying to talk to each other to try to reach consensus. That's the Dutch polder system. And the interesting thing about tapering research is that it's very difficult actually to introduce tapering research in the Dutch polder because there's not exactly consensus about it. So that's what makes this story interesting. Of course, I want to acknowledge Peter Groot. Peter Groot actually invented tapering strips, and I've been collaborating with Peter for 10 years doing this research, and he'll be presenting his story about tapering strips in this World Tapering Day conference. And I will focus particularly on the results of the research, and I'll give a brief introduction as well. So what is it all about? Well, this is the Netherlands, and the areas in yellow that you can see here are the areas that have high prevalence of antidepressant use, usually in women. And the interesting thing is that it has been noted that these areas conform mostly with what is called the Bible Belt in the Netherlands, meaning the more type of strict Protestant religious affiliations that tend to be here. And of course, this immediately calls into question the whole notion of prescribing antidepressants for women. So we can think we follow evidence-based guidelines, but then if you give back the data at the population level and you ask prescribers to reflect on it, they also see these kinds of things. So that's what I find so interesting about this population level pharmacoepidemiology data. It also gives back to us what we are doing, but in a very different fashion. So we were quite interested and a little bit disturbed by this, of course. Also, because we know that withdrawal associated with widely prescribed antidepressant medications was already noted more than 60 years ago. The areas in yellow I just showed you are the areas where up to 13% of the adult female population is treated with antidepressants, and the darker areas were up to 6%. So if you take into account withdrawal, then what does withdrawal actually will do with such high prescription rates in the general population? Well, as you can see here, likely it will do, it will manifest itself very frequently in the population, but as you can see here, it will not, the phenomenon of withdrawal will not manifest itself in academia. You can see here the number of articles writing about withdrawal is virtually nothing compared to the articles writing about antidepressant treatment trials on the right. So it's a difficult topic. It's an underreported topic, and therefore we were quite interested in this phenomenon. Now, as you all know, and indeed this is the very topic of the conference, if academia and prescribers do not take into account a very important topic like withdrawal, then of course patients themselves, users, will come up with creative solutions. And of course we know Will Hall, who wrote the widely published and distributed booklet Coming of Psychiatric Drugs, very well known. Of course we know Adele Framer, who has helped countless individuals using internet-based peer support, and of course Peter Groot, you see his picture here, who has now become very well known because he developed actually the tapering strip, helping people to come off antidepressants so that they don't have to experience withdrawal. So this is really about a user invented, a user promoted scientific innovation. That's what's so interesting about the tapering strips. And we now also know, of course, that the basis of withdrawal is there's a likely biological substrate for withdrawal, namely what is called the oppositional tolerance phenomenon, namely that the brain tries to compensate for the antidepressant effect, and then if the antidepressant is taken away, you get a huge overshoot of serotonergic or noradrenergic or both input, causing things like relapse and rebound and withdrawal and persistent withdrawal, or loss of clinical effects and all sorts of paradoxical reactions. These were not taken very seriously by us, the psychiatric profession, but are now fortunately slowly introducing themselves into the medical curriculum. Now, the development of the tapering strips was very interesting because already in 97 there was somebody writing in the British Journal of Psychiatry, why don't we make curated dose packages, calendar packs? And then there was a person in 2004 writing in a Dutch newspaper, I've got an idea, I want to make a medication withdrawal strip. And then finally in 2011, Peter Groot, who by training is a geneticist and a chemist and has a PhD, then said, I've got an idea, I'm going to make this tapering strip. And then there was a non-profit pharmaceutical who actually asked Peter, okay, let's do it. And then they couldn't find anybody who wanted to make the bloody strips. But fortunately, eventually they found one pharmacist in the whole of the Netherlands. There was only one pharmacist who said, okay, I will do it. I will take up the challenge and try to make these daily pouches with reducing the dosage. So every day you have a new pouch with a little bit less than the previous one for 28 days. And so you had the monthly tapering strips. And this, of course, was very important because it means empowerment. It means a tool for shared decision making. How should we, stop or discontinue antidepressant medication? How rapidly? It's ideal for shared decision making. It's also scientific because tapering strips already avant la lettre introduced the idea of hyperbolically reducing the dose so that in the brain there's a linear reduction in the concentration of the critical neurotransmitter substances. Ideally, theoretically, there would be broad societal and medical support. You would expect that because it was such a brilliant invention. So yes, Peter Groot got societal recognition. Last year, and this was really very special, this is why I mention it, he was awarded a very, very important distinguished royal distinction that indeed very few people receive. And we think this has something to do with the Queen's personal or family encounters with mental suffering. And so Peter rightly was here the mayor of Utrecht who actually bestowed upon him the royal distinction. So this was very, very impressive. But the interesting thing is, and this is also the Netherlands, I think, that there was societal recognition, but there was no recognition from the system parties in healthcare, like the Royal Colleges of Psychiatrists or the GPs or the mental health care organizations or the healthcare insurers. They all actually did not acknowledge the importance of his innovation. And I think this may have something to do with the fact that Peter is a user. he's a patient. So this was something that was developed, which may be the most important psychopharmacological tool in the last 50 years. It was, however, not taken up by the system parties in healthcare because of the not invented here syndrome. You often see that because it's very special if a patient introduces such an important innovation. It's almost too much for the system parties to acknowledge, so that they will have to rebrand it and reinvent it themselves, and then appropriate it and introduce it as belonging to themselves. This is a well-known sociological phenomenon. I don't think we should be too negative about it. It's also understandable these things happen. So we have now the situation in the Netherlands that, of course, tens of thousands of individuals have used tapering strips, but they're not reimbursed. So if you happen to have an antidepressant that makes it possible, that has small dosages that allow you to stop gradually, then your tapering is reimbursed because the dosages you require to slowly stop are already there. But if these dosages don't exist because the pharmaceutical company didn't make them, then you're in a bad position because, of course, you can use tapering strips, and the pharmacist can make them, but then they will not be reimbursed. So you can be reimbursed if the pharmaceutical company made small doses, but if somebody else has to make these small doses, you cannot be reimbursed because they say this is a novel medication. You're introducing a novel medication on the market. Therefore, you have to bring randomized controlled trials. You have to build up an enormous file and a European application, etc., etc. So it's nearly impossible. So this is the situation that Peter met when he introduced his tapering strip. This is what also helped us to do the research, because patients are widely using tapering strips but paying for them themselves. And the beauty of that is all these patients are very, very willing to also participate in research because they think it is important to conduct scientific research. So there's a whole glossary of tapering. You can find it in this article that Peter and I wrote in Therapeutic Advances in Psychopharmacology in 2021. So it's all sorts of tapering methodology and glossary that is associated with it. You can read on it. Now, of course, the research is to build evidence. And the question is, what sort of evidence do we need to show that tapering strips work and indeed offer a solution for a substantial proportion of people that have difficulty stopping antidepressant medication? Of course, you want to have ideally a systematic review of randomized controlled trials. In evidence-based medicine, randomized controlled trials still are the golden standards. But cohort studies, so following up people who are choosing to or are using a medication and following them over time, perhaps comparing them to people who do not use this medication or comparing it to the person before he used this medication, is also quite a high level of standard of evidence in evidence-based medicine. So you want randomized controlled trials or cohort studies. And of course, with tapering strips, it's very difficult to organize a randomized controlled trial because, tapering is very personal. Do you want to taper in a month or in 3 months or 4 months? You have to find your way. You have to stabilize perhaps for a month and then continue, or you have to go back to a higher dose for a while and then continue. So it's a very messy, personal procedure. And therefore, it's very difficult to test in a randomized controlled trial against placebo, because that's what most medical scientists will tell you is required. You have to test tapering strips against placebo. Never mind that you will not find patients who are willing to do that, of course, because then what you're basically testing is whether people develop withdrawal symptoms. But we also already know that people develop withdrawal symptoms. So it would be cruel and probably ethically not feasible to organize a randomized controlled trial using tapering strips. So therefore, we focused on cohort studies of people using tapering strips. Because of these many people who have used them, we conduct research with these people. And also recently in the Netherlands, we had a report, a very interesting government board report, saying that the illusion of evidence-based practice in healthcare. Many things that we say should be tested in evidence-based situations like randomized controlled trials simply cannot be tested in a randomized controlled trial because there is such huge personal heterogeneity and variation that you can never test it in a randomized controlled trial against placebo, because a randomized controlled trial is always about a standard situation. But since there is no standard patient in terms of withdrawal and tapering, this is impossible. So we were supported by their report. Now, what we have done in the first 3 studies, you can see them here. This is where Peter actually describes the importance of user knowledge in the development of person-specific tapering medication. And I highly recommend reading that article. And then we produced 3 cohort studies, so high level of evidence in evidence-based medicine. And these were simply cohort studies asking people who had been using tapering strips for a month or 2 months or 3 months or 4 months to come off their antidepressant medication. We simply asked them, after 1 month or 2 months or 3 months, have you been successful? Did you succeed in reducing your medication? And since these were mostly people who had been trying to come off medication before without specific tapering medication, we simply asked them, what was it like reducing your medication with tapering strips compared to before without tapering strips? So we compared the person with him or herself, which scientifically is a very strong paradigm. Okay, so then there were 2 studies like that. And in one study, the middle one here, was special because in that study, we asked people not to report on the success of tapering strips, not just after they use tapering strips, but after 1 to 5 years later. Were they still off antidepressant medications 1 to 5 years later after using tapering strips 1 to 5 years before? So this is also very important evidence that you want to have about the persistence of the effect of tapering strips. So let me summarize the results. Basically, the 4th study we also did, I'll talk about later. That's the most recent study. But in the 3 studies, simply what we did, you can see that here on the left. So we asked them, how did the tapering go? And then on the left, you see the rating for the tapering trajectory when they were not using tapering strips. And on the right, you see the tapering trajectory when they were using tapering strips. And you can see this is almost a mirror image. So the higher the score, the more poorly the tapering trajectory was. So it went very badly badly or very badly for the majority before using tapering strips, and it went on the contrary, it went very well for the majority when they were using tapering strips. So this is, I think, very convincing evidence. Yes, it is not randomized. Yes, of course, it can be biased. I mean, maybe these people felt obliged to report the tapering strips were helpful, but since they paid for them themselves, you might expect them to be really critical as well if it didn't work. And of course, we could not include everybody who we wrote to because we had 3,000 patients, but there were many more who used tapering strips. So of the 10,000, we had 3,000. So maybe like 20% sent back the forms. So, but the thing is, we replicated this 3 times in 3 different samples, and I think that is important to bear in mind that replication is really the stuff of science. And it's very unlikely that there would be a consistent bias that each time we did an analysis would report in the same direction. That's nearly impossible. And here you see, did they experience withdrawal symptoms? Yes, very high level of withdrawal symptoms when they tried without tapering strips, and much lower, but still, that's interesting. It's not completely the mirror image. There's still withdrawal, considerable withdrawal when they use tapering strips. But as you can see here, much less than when they did not use tapering strips. So I also find convincing, and that people try to report accurately and not just were trying to please us, tell us what we wanted, or what they thought we wanted to hear. So I think this is very important. It's cohort study level. So the tapering strips have cohort study evidence, but the guidelines, that's very important. The guidelines in the Netherlands are still based on an old expert opinion report by the system parties. And of course, we all know that the lowest level of evidence anybody can use in clinical practice is expert opinion. This is well recognized. Expert opinion is very, very, very bad evidence. But still, the system parties, and particularly the insurers in the Netherlands, hold on to saying, no, expert opinion is better than cohort studies in evidence-based medicine. And of course, this is also interesting. I think we have to give, and it also shows how much time you have to give to the system parties involved in healthcare before they can accept patient-driven findings. Because, of course, user research is expanding, and it's having a place in medicine, but there's also enormous barriers for system parties to accept seriously user research. And what we are seeing here is really the stuff of history. I am convinced that in a couple of years' time, this will all change, and that we will look at this from the medical historical point of view, how user research really came to empower itself with such an important topic as withdrawal and tapering strips. So here you see the results of the 3 studies. So the response rate was about varied between 50 and 70%. And they were quite large samples, much larger than you would see in any randomized controlled trial. They were mostly women, and the mean age was 50, and this is compatible with the demographics of antidepressant users in the Netherlands. So it suggests our samples are representative of the population we wanted to target. Most medications most often used were venlafaxine and paroxetine. And this is very interesting because they are overrepresented in our studies compared to the number of people in the general population using them, suggesting that they have properties that are more likely to cause withdrawal. So very interesting. And actually, I never tell, when I teach my younger colleagues, I tell them never use paroxetine or venlafaxine. Even you have to think very carefully if you want to use an antidepressant at all, because the evidence is weak. But it may benefit some people perhaps, but don't use venlafaxine and paroxetine. And then you can see that success rate was 70%, around 70%. And also in the subgroup of people who had attempted unsuccessfully previously. This is very important. And the most important risk factor for withdrawal and not being able to come off previously was the length of use of antidepressant medication. That was the most consistent, and more previous attempts. Those were the most consistent risk factors. Very interesting. So here you see a short summary of the results. So most participants were long-time users. Many of them had tried to taper previously. So this was really, really the population with the most severe withdrawal. the most difficult people to help to come off their antidepressant medications. And still, tapering strips had a 70% success rate. So that's high. They rated tapering strips as much easier to use than previous methods. They rated tapering strips as occurring with much less withdrawal. And of the ones that successfully tapered strips, 72% was still without antidepressant 1 to 5 years later. Okay, so this is an interesting finding. What we also found very interestingly is that the majority of patients did not hear of tapering strips from their psychiatrist or their general practitioner. They heard it from mostly internet and other patients, interestingly, and the press. So this shows you that this is, again, this sociological issue that for the medical profession, it's very difficult to embrace a method that was invented by users and researched by users, because that creates the not invented here syndrome that creates resistance to the medical profession. Of course, this will wane, this will go away with time, and is a well-known sociological phenomenon. Now, this is our last study. I want to conclude with this. This is our last study, and I think the most interesting study by far. Because what did we do this time? Well, we wrote to 600 patients. Now, in the last couple of years, each patient that receives a tapering strip receives a daily rating instrument where they can very briefly rate the amount, the level of withdrawal they are experiencing each day, together with, when they use the tapering strip. So for a 28-day tapering strip, they rate 28 days of how severe the withdrawal was that day. If it's 56 days, they use 2 tapering strips. They rate for 2 months how severe each day, how severe the withdrawal was. So what you can see here is how the dose reduction takes place in the tapering strip. So you can really see that each day the dose of the antidepressant medication is very, very, very gradually reduced. You get this curved reduction. This is people who are using for 28 days. You can see here, many of them could have gone on. We don't know that. So it seems as if they don't complete their reduction, but they could have gone on longer. And this is people who've been using for 56 days. So you can see this curved line again, slightly curved line of hyperbolic tapering. And this is people who did it over 3 months. So you can clearly see that if you taper over 1 month, it's more rapid than if you do over 2 months. And 2 months is more rapid than if you do it over 3 months or 4 months or longer than 5 months. This is really a nice curved, very gradual reduction. So this is how the dose reduction takes place. And this is the withdrawal that people reported. And this is actually the first study ever to rate on a daily basis what happens with people's withdrawal when they use a tapering strip to reduce their medication. And you can see, even though they very, very, very gradually, hyperbolically reduce their medication, they still develop withdrawal. You can see here, this is 1 month. So this is the severity of withdrawal. It goes from 1 to 7. So you can see that they go from very little withdrawal, 1, to about 2.5 maximum. So that's not a lot of withdrawal, but these are the means of 600 people. So some of them will have very high and some of them very low. But it shows that on the whole, the withdrawal seems manageable, but goes up. It goes up very rapidly in the beginning. You can see that here. And then it levels off. But at the end of 28 months, it hasn't started to come down yet. And what you can see here, those who use longer periods, like 56 days, to reduce their antidepressant medication with tapering strips, they go up, but you can see here they go up here, but more gradually, and then they go down, and they go up a little, and then they go down. So they take it long enough to eventually feel the withdrawal coming down again. So it seems that 1 month, it may be too short for many people, and maybe 2 or 3 months or even longer is a better way to gradually reduce. And this is what we also found in our previous studies, because the median number of tapering strips people use to reduce their antidepressant medications is 56 days. It takes most people 56 days to use tapering strips to reduce the antidepressant medication, which makes tapering strips, of course, very cheap, because it's maybe like 150 euro for a tapering strip. So in all, it's 300 euros. And that's very, very cheap, because it's the same as a year's worth of medication. But think also of all the complications that you're going to prevent, the falls and the cardiovascular problems and the persistent sexual side effects that may arise, and persistent anhedonia, that sort of thing. So tapering strips are not expensive, of course. They're very cheap, and they give good results. What we also saw, and this is an important finding, we had some inkling of this in our previous studies, but because this is a much finer, refined methodology, is what we see here is that women suffer more withdrawal than men. And this is an important finding, I think. Regardless of whether it's 1 month or 2 months, 3 months people use, women have more withdrawal. And it may be that in general, the notion of emotions being painful, of course, is more prevalent in women anyway. So we think this pain, this emotional pain, is caused by withdrawal itself. It's part of the rebound that you can see if you try to reduce antidepressant medications. Part of the rebound is emotional pain that then comes up more severe in women. So we think this is an important finding. Another finding is age. If you go from top to bottom here, for example, in 28 days tapering or 56 days tapering, you can clearly see that older people, those over 60, have less withdrawal than those between 35 and 60 or under 35. And this is very interesting, because you also know from neurochemical studies that these neurotransmitter systems, like the dopaminergic system and serotonergic system, are more edgy and more active and more dynamic in young people. They lose some of that edge with age, it seems. So some of that actually you may be finding back here. So we think this is also a very important finding. And here we studied it by using modeling interactions at a weekly basis. You can clearly see that women exceed in withdrawal on a weekly basis than men in the interaction model. And here the oldest age group in green, age 60 and older, also clearly has a lower level of weekly withdrawal than the other age groups. So important findings. And finally, a last thing, because in the Netherlands, one of the interesting but also irrational things in the consensus expert opinion document was that it was recommended that those reductions in antidepressant medication, in helping people to come off antidepressant medications, should not be on a daily basis using very small steps, but should be carried out in larger weekly steps. And of course, this doesn't make sense from a withdrawal point of view, because the larger the step, the more likely you will provoke withdrawal. And this is indeed what we see. So the expert opinion of weekly tapering actually causes more withdrawal than the hyperbolic daily tapering. And this was entirely predictable, but that's also the interesting thing, is how persistent expert opinion documents can be. So it's called the consensus document in the Netherlands, and it's still sort of the magic that people have for expert opinion, even if it's irrational. And another interesting thing was that the expert opinion on weekly tapering was especially difficult for people using paroxetine or other antidepressants. So there, the weekly tapering caused much higher withdrawal for both other antidepressants and paroxetine than the daily tapering. So very interesting. And we didn't see that with venlafaxine. So venlafaxine may not be sensitive to weekly or daily tapering, although I think we should still do daily tapering. Doesn't make a difference in price or anything. So that's an interesting finding. So to conclude, I think really we should keep our eye on the ball. And what this research really is about, I think, is about what we call the era of the moral era of medicine. The moral era of medicine, you can see here this call for era 3 for medicine and healthcare in JAMA, which is the most famous medical journal in 2016. And it was written by Donald Berwick. And he says medicine should transform itself to become more moral. And with moral, he means they should not portray this idea of the doctor being the expert who knows everything and who can do anything and who will decide for the patient. The doctor really should acknowledge that he doesn't know anything about what makes a particular patient tick. What things are important in life for this particular patient, and how may it completely differ for a patient with perhaps the same diagnosis, but with a completely different set of values of what is important in life. And the moral era of medicine means that as doctor, the first step you should take is to listen to your patients and try to find out what is important to them and take them seriously if they say they have withdrawal symptoms that you, as a medical professional, have not developed eyes to see yet because you've kept yourself blind and you're in the blind spot. And if you listen to your patients, you can help you cure yourself of your blind spots. So this is the moral era of medicine. It has also to do with open science. Open science is basically about science trying to be relevant. So not to peer into people's brains all the time or peer into their genetics as if the answer to mental illness is there. No, it's trying to actually look at people's lives in context and trying to make the difference there in the context of people's lives where things happen. So this article we wrote about tapering strips really representing the ultimate dossier where the patient is not being heard, not for 1 year, not for 5 years, but already for 60 years. And that is why we should be so incredibly grateful to people like Peter Groot, Will Hall, and Adele Framer, and many other people in helping us to, become better carers by developing eyes and ears to listening to other people. So thank you very much for your attention, and thank you very much, Carol, for bringing this all together. You're really fantastic in having done that.